Welcome to a presentation on normal female pelvic ultrasound. There are many indications to obtain a female pelvic ultrasound. Pregnancy will be discussed in a separate presentation. Frequently, women will have a mass that is palpated on physical exam. Some things that can cause this palpated mass on physical exam include large ovarian tumors, congenital abnormalities of uterine shape, and uterine fibroids, all of which can be distinguished on ultrasound. Another indication is pelvic pain. Some things that can cause pelvic pain are pelvic inflammatory disease, ovarian torsion, ectopic pregnancy, appendicitis, inflammatory bowel disease, or diverticulitis. Another indication for a pelvic ultrasound is abnormal vaginal bleeding. Some things that can cause abnormal vaginal bleeding are pregnancy, menstruation, precocious puberty, and postmenopausal bleeding. We can also use ultrasound to evaluate for appropriate positioning of an intrauterine device and to evaluate fertility, perhaps due to polycystic ovarian syndrome. Pelvic ultrasound modalities. Ultrasound is a safe way to image the female pelvis as it does not expose ovaries to ionizing radiation, which we know to be mutagenic. Two ultrasound methodologies that we use are transvaginal and transabdominal. The transvaginal modality requires a specialized endocavity transducer that is inserted into the vagina. The transabdominal ultrasound uses a transducer that is moved superficially across the abdomen. The diagram on the right depicts the use of an endocavity or endovaginal transducer. Only the upper surface of the transducer can transmit sound waves. Therefore, take note of the small curved transduction area. We will use this to differentiate transvaginal imaging from transabdominal imaging on the next slide. A transabdominal image is shown on the left and a transvaginal image is shown on the right. We can tell which probe was used for which image by looking at the curvature on the top of each image. Looking at the image on the left, the wider curvature, in other words, the curvature corresponding to a larger radius, corresponds with the curvilinear probe, which is depicted on the bottom left of the screen. For the image on the right, we see a smaller curvature corresponding to a smaller radius. This fits the curvature we see on the endocavity transducer, which is used for transvaginal ultrasounds. To do a transabdominal pelvic ultrasound, the patient should have a full bladder. A full bladder lifts the small intestine out of the pelvis and creates an optimal acoustic window for ultrasound imaging. Gel is placed on the lower abdomen to ensure air-free contact between the curvilinear transducer and the skin. The uterus, if you look on the image on the right, is immediately posterior to the bladder on the transabdominal approach. Unlike the transabdominal ultrasound, the patient does not need to have a full bladder for a transvaginal ultrasound, as the acoustic signal does not need to traverse the bladder. For transvaginal imaging, let's first discuss where we are going to place the endocavity transducer. There is an area that surrounds the external os of the cervix, known as the fornix. This area is incredibly elastic, which is why we will try to place our probe in the anterior portion of the fornix to visualize the uterus, which is labeled in the diagram on the left in red. The other main structures we want to visualize are the cervix and the ovaries. We want to make sure the cervix is at a certain length, and we want to make sure the ovaries are normal for where the woman is in her menstrual cycle. Please note, the parietal peritoneum drops anterior to the uterus between the uterus and the bladder to form the vesicouterine pouch. It also dips below the uterus and the rectum to form the recto-uterine pouch, which is sometimes referred to as the Douglas's cul-de-sac or the pouch of Douglas. We will be able to see that on the next slide. Now let's take a look at a transvaginal ultrasound image and try to locate some major structures. I've put the previous image of the anatomy on the left, which will help us orient ourselves. Let's approach the image on the right systematically. At the top, we see a sharp curvature, which corresponds to the endocavity transducer, so we know that we're dealing with a transvaginal image. Immediately below, we see an arrow pointing to a hyperechoic layer, hyper meaning more, and echoic meaning able to return sound waves more so than surrounding structures, and thus appearing brighter. This is the perimetrium, or the serosal covering of the uterus, and we can trace it from the top of the image, along the left side of the image, down to the bottom. It is labeled with an S. Within the perimetrium, or serosa, lies the myometrium, or the muscular portion of the uterus, labeled with an M, and the endometrium, the innermost layer of the uterus, labeled with an E. The endometrium is clearly visible because it appears as a hyperechoic line, brighter than the surrounding structures. There is a portion of the myometrium that has been labeled J for junctional zone. This is a region of the myometrium that is frequently affected by different gynecological pathologies, for example, uterine adenomyomas, so it is important to know and understand its location. Depending on where the patient is in their menstrual cycle, the endometrium will vary in thickness. On the upper right, we see the cervix, which is a strip of hyperechogenicity, much like the endometrium. Directly posterior to the uterus, anatomically, is the recto-uterine pouch, or the pouch of Douglas, which is labeled PD in the image. The last structure we want to visualize is the ovary. As a quick reminder, we can see the process of follicle development on the left in response to hormonal stimulation during a patient's menstrual cycle. Specifically, during the follicular phase, 5 to 20 follicles are stimulated simultaneously in response to follicle-stimulating hormone, FSH, although only usually one ovum ovulates. Once ovulation occurs, the remnants of the follicle become the corpus luteum and produces progesterone and estrogen to support the pregnancy until the placenta can take over. The ovaries can vary in size depending on where the patient is in their menstrual cycle. On the right, we can see arrows pointing to the ovary. As you can see, within the ovary, there are several hypoechoic regions, which means less echogenic than surrounding areas. These hypoechoic regions that appear dark are the developing follicles within the ovary. In summation, we discussed the two modalities used to image the female pelvis. We talked about the transabdominal approach as well as the transvaginal approach. Additionally, we discussed how to distinguish between transabdominal and transvaginal images. We discussed pelvic anatomy and how they appear on ultrasound imaging. We talked about the uterus and the 3 layers of the uterus, the serosa, the myometrium, including the junctional zone, and the endometrium. We also discussed how to locate the cervix and what a normal ovary during follicular development looks like. Thank you very much for your attention.